This is Betty Farrell, and I would like to welcome everyone to our session now. This is our public session. As chair of the committee and of this study, I would like to welcome everyone. I'm Betty Farrell. The task that is being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to examine how our nation delivers, finances, regulates, and measures the quality of nursing home care. The committee's full official statement of tasks can be found on the project website. Today's open session will feature short presentations by the project sponsors, which includes the John A. Hartford Foundation, the Commonwealth Fund, the Sephardic Foundation on Aging, the Jewish Healthcare Foundation, and the Fan Fox and Leslie R. Samuels Foundation. After their remarks, the sponsors will then entertain questions from the members of the committee to help clarify the scope and the intent of the statement of work. I want to note that this is an open, on-the-record session. Interested individuals from the public have been invited to attend as observers, and we will not be entertaining questions from the floor. Please do note, however, that anyone can submit testimony or other materials to the committee at any time, and these documents will be placed into the committee's public access file. So you can submit any of this information through the project website. I would also like to remind everyone that this is an information gathering session. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. Before we hear from our sponsors, I'd like to ask each of our provisional committee members to briefly introduce themselves. Also, please note that their bio sketches can be found on the project website. So I will turn to our committee and just ask each member to briefly introduce themselves, their name, and their affiliation, so that we can just do a brief introduction and save our time to hear from our sponsors. So we'll begin with Gregory Alexander.
Gregory, you're muted.
That would be good to start off with unmuting myself. Hi, I'm Greg Alexander. I am a Holland Young Cofsonate professor at Columbia University School of Nursing, and I am so happy to be here. Thank you.
Hello, I'm Mary Ursek, and I am professor of nursing and also with a secondary appointment in the School of Medicine at the University of Pennsylvania. In addition, I have a joint appointment at the Department of Veterans Affairs.
Is Colleen with us?
Yes, I'm Colleen Galambos. I'm the Helen Bader Endowed Chair in Applied Gerontology at the University of Wisconsin-Milwaukee, and I have an adjunct professor appointment at the Medical College of Wisconsin.
Hi, everyone. I'm David Grabowski. I'm a professor of healthcare policy at Harvard Medical School. Delighted to be here today.
Hello, I'm Kathy Greenlee. I previously served as the U.S. Assistant Secretary for Aging and the Kansas Secretary for Aging. I currently have my own private consulting business in Kansas City.
Hello, I'm Lisa Kaplowitz. I'm presently Deputy Health Director for Public Health in Arlington County, Virginia.
Hello, everyone. I'm Tamara Konecka. I'm a professor at the University of Chicago in the departments of Public Health Sciences and Medicine.
Hello, I'm Christine Miller. I hold the long-term care professorship in nursing at the University of Minnesota School of Nursing.
I'm Marilyn Rance. I'm a curator's professor emeritus at the University of Missouri in the Sinclair School of Nursing and in the Department of Family Medicine.
Hello, I'm Deborah Saliba. I am a professor of medicine and geriatrics at UCLA. I'm also with the Los Angeles VA Veterans Administration system and with the RAND Corporation.
Hello, this is Bill Scanlon. I'm a consultant with West Health. I'm very happy to be here today. Thank you.
I'm Philip Sloan. I'm a professor at the University of North Carolina, Chapel Hill. Also very pleased with this committee and being part of it.
Hello, I'm David Stevenson, a professor in the Department of Health Policy at Vanderbilt School of Medicine. Also very grateful to be here.
Hello, I'm Jasmine Travers, assistant professor at New York University Roy Myers College of Nursing, and delighted to be here as well.
Hi, I'm Reginald Tucker Seeley, the Edward L. Snyder Assistant Professor of Gerontology at the Leonard Davis School of Gerontology at the University of Southern California, and very excited to be a part of this committee.
Hi, I'm Rachel Warner. I'm professor of medicine and healthcare management at the University of Pennsylvania and am also at the Veterans Health Administration in Philadelphia.
Thank you, everyone. So for our sponsors, I think, as you know, today is our first day to be together as a committee. So we are just beginning our work and also beginning to know each other. But I think you can see we have a wealth of experience and knowledge that have come together in this committee. We spent the last few hours just really introducing ourselves, but I can tell you that there's tremendous commitment and real passion for this work. And also every one of us at this table recognizes what a privilege it is, particularly at this time in our history, to be able to do such important work as to address the quality of care in nursing homes. So on behalf of the entire committee, I want to thank each of you as sponsors, because we know it truly is your commitment that is making it possible for us to do this work. I'm going to be introducing each of you as sponsors, and we will ask you to make your brief comments, and then I'll be inviting the committee to ask specific questions or react to statements that you have shared with us today. So I'll begin by inviting Terry Fulmer, president of the John A. Hartford Foundation, to address the group.
Thank you, Betty. It's nice to see you today, and thank you to everyone for their willingness to serve on this most important committee. My passion for this stems from a career focusing on improving care for older adults, and my research, my NIH-funded research, has been on the eradication of elder abuse and neglect. I'll say, as background, in the early 1980s, we had an elder abuse and neglect team at the Beth Israel Hospital in Boston, learned about a lot about quality of care in nursing homes and a lot about the lack of quality of care in nursing homes. We all know that the last study that was conducted on this topic for the National Academies was 1987, 86, 87. And we are well due for this study. And I would add that it really took COVID to tip us over into this harsh, harsh light. So thank you for your commitment. And I'll say a couple words about the foundation, a couple reasons why we're doing this, and then turn it back to you. So next slide, please. The mission and priorities of the John A. Hartford Foundation are as follows. The mission of our foundation is to improve the care of older adults, no matter where they are and no matter who is providing that care. We do that through three approaches: creating age-friendly health systems, because as I often say, there's no such thing. And a health system starts at your kitchen table, should get you back to your kitchen table. We're very focused on that. Support for the 40 million family caregivers out there who are beside themselves, on a regular basis, and now imagine with COVID. And then improving serious illness and end-of-life care. And so we are right in the middle of the work we do as we watch the news unfold every day with 100 cases every day. Hard to imagine. Next slide. So COVID infections and deaths, this is as of yesterday. So what I'd say is remember 50 million global cases, 1.2 million global deaths. Our US cases, so noted on the screen, 237,000 deaths, and our nursing homes have disproportionately taken the tremendous burden and toll of this virus that one could not have imagined a year ago. So our nursing home resident cases are noted on the slide, 281,000 as of 10/25 CMS data, and US nursing home deaths 63,000 as of 10/25 CMS data. So we know it's larger now, but the numbers are just so staggering. Next slide, please. So COVID-19 in nursing homes, what have been the big issues? And the investigators on this panel, as well as all of us around the country, know that we have been confronted with the huge issue of staffing, infection prevention, personal protective equipment, social isolation, and the horrific racial and ethnic disparities that have gone along with COVID-19 in nursing homes. In partnership with Chris Kohler from the Milbank Foundation and Jack Rowe, who's at Columbia University, we wrote recently in a NAM perspective that America's nursing homes are not designed, operated, or funded to deal effectively with infectious disease epidemics. And their staff are often too few in number, inadequately paid, protected, and trained. That's why we're here today. We all know that. Next slide, please. The disaster presents an opportunity to fundamentally reimagine the future of nursing homes. And that's what I am so optimistic this study group will do, is reimagine completely where we're at with nursing homes. Next slide, please. I want to comment on a couple of things that our foundation has done, and also tell you that we're committed for the very long-term future. When at the end of March, our trustees joined together with us as a staff to say, what would we do urgently to put a stake in the ground and help with this crisis of COVID in nursing homes? And then what would we do emergently? So urgently, we set up our national nursing home huddles led by the Institute for Healthcare Improvement in Boston, Massachusetts, where we work with our Age-Friendly Health System initiative. They pivoted immediately, and we set up an 18-week curriculum, which has now been picked up by AHRQ, the Agency for Healthcare Research and Quality. Our $300,000 grant became a $255 million grant to make sure that all 15,000 nursing homes in this country have equal access and participate in the ECHO project along quality and safety for nursing homes. Emergently, we made a grant to Frameworks Institute. Many of you know Nat Kendall Taylor and his great work on reframing aging and reframing elder abuse. And Nat is working on reframing nursing homes, and he is following your work very carefully and very closely as you go along. And he'll learn from you, and we'll all learn from Nat. And then emergently, obviously, our National Academies of Science, Engineering, and Medicine, launching our study today on nursing home quality and safety post-COVID. So critical. And I'm grateful to the trustees of the John A. Hartford Foundation that they pivoted like that, and that the staff did too. So thank you everyone who has worked with us in this effort. Next slide. I served on the Commission for Safety and Quality in Nursing Homes, the CMS Commission that reported out September 16th. There were several other commission members in this committee today. So the commission reported on 10 themes, 27 recommendations, and 100 action steps. And that was staffed by MITRE. Many of you know that company is quite expert in ensuring that these types of charges get addressed and executed. So the themes that you see here, these 10 themes, are ones that I will say we had the kind of I'll call it just good fortune in a way to have that commission happen before this study, because so much of what that group has done will inform this committee, and you can amplify, clarify, verify, but a great deal of work has been done. And what I would say with the testing, the PPE, the cohorting, visitation, communication, workforce, technical assistance, data, all of that will be a part of the conversation that goes on during this study. I would say the report is just one step toward eradicating elder mistreatment that can result from inadequate care, whether it's intentional or unintentional, but I will always harken back to that given my background and what I've worked on in my career. Next slide. So that commission report got released, and on September 16th, as you might be able to see on the slide, there was a report that came out, and it said the Independent Nursing Home COVID-19 Commission findings validate unprecedented federal response. There was a report, there was a headline that said validated unprecedented federal response. That would be the most optimistic view, but it isn't what we've been seeing on the ground. And so I just put a pin in that for all of us. To the right, you see a very recent November 5th health affairs blog by Karen Wolf-Feinstein, who will be speaking in a few minutes, about the report issued 6 months after our nation was aware of the death toll in nursing homes failed to present a bold new vision for skilled nursing care. So there you have it. What many of us are looking for is a bold new vision. Next slide. Reimagining nursing homes, then, really we can redesign physical and operating models to accommodate future pandemics. But I'll remind you that most nursing homes were built about 40 years ago. And one really can ask the question, can we really redesign what we have in place now? But what we can think about is, should we have more homogeneous group placement? Should we have hospice centers and memory centers instead of putting everybody together in one place where their own personal goals and preferences and the goals and preferences of their families may not be met at all? Facilities, there's been a lot of enthusiasm about greenhouses, and I'm enthusiastic as well, not knowing what that would look like in terms of finances and regulations, but there's a lot of promise when people talk about smaller facilities. Nursing home alternative, the PACE day centers, which people couldn't go to during COVID, but PACE in the home has had quite dramatically positive results in terms of keeping older people and their families safe. Short stay rehabilitation patients in extended care wings, something that I have written about. I would propose that the Mass Generals of the world, where I have previously been on staff, could have an extended care wing right there in front of them. They've got their personnel, their personal protective equipment, their staffing right in that location. So why do we move people around? Something for the committee to consider. Next slide. We will need action by all stakeholders. Medicare and Medicaid policy reform, and I am confident that our colleagues in CMS want to be a vital part of the solution. Investment and change by the industry itself. We'll hear comments from others about what nursing home got sold today. Research on redesign and financing is vitally important. And I know that NIH and NIA in particular is thinking about this a great deal, along with all of our agencies at the federal government. Advocacy on behalf of residents and families. We have seen the headlines that say nursing homes are death traps versus that nursing home saved my mother and had a symphony in the hallway for them. There will be good actors and bad actors, but we have to have advocacy. Funding from philanthropy and the public sector. This is going to take a lot of money, and we will hear how state Medicaid budgets have been decimated, but what do we need to think about going forward? What will bundled payments do in order to help us with this conversation? And we do need follow through on the Commission's 27 recommendations. They were solid. If not bold and creative, they were certainly baseline. And so I think we all have to look at it very, very carefully. Next slide. So the charge to the study committee from the John A. Hartford Foundation. The public, in many ways, has given up on nursing homes. We've heard people talk about horrible phrases like culling a herd. What kind of language is that in the United States of America? We've also heard people say, well, we might as well throw in the towel. We just can't fix them. Well, we must. It's our commitment. Our society loves longevity. We love to say that, you know, we've doubled life expectancy since the turn of the century. Now we have to double expectations about care quality. We have to make sure that this committee that carries a tremendous responsibility will produce a report that's actionable, results in timely policy changes. Has to be timely, that will ensure quality and safety in nursing homes and for the long term, and reflect bold thinking, unconstrained by existing laws, current structures, or societal norms. So, next slide, please. In closing, what I want to say is we're talking about nursing homes. I am completely aware of the continuum of long-term services and supports, and I am very, very fundamentally interested in improving the quality and safety in that arena as well. But we're talking about nursing homes for this study. It's a big task, and I know that you're all up for the task. I'm grateful to each of you, and I'll turn it back to Betty. Thank you.
Thank you so much, Terry. I think all of us have already been guided by your personal passion. We really thank you. And we also thank the John A. Hartford Foundation for supporting this work. And we certainly will listen to each of your comments you've charged us with today. Let's go on now to Gretchen Jacobson, Vice President at the Commonwealth Fund.
So good afternoon. It's a real pleasure to be here at this meeting. The Commonwealth Fund is honored to help fund this study and to be here on the first day of the committee's meeting. The mission of the Commonwealth Fund, we go to the next slide, please, is to promote a high-performing healthcare system that achieves better access, improved quality, and greater efficiency, particularly for society's most vulnerable populations. We expect that this study will further the mission of the fund by helping to improve the nation's long-term care. Next slide, please. The last National Academy study, on nursing home quality had significant impacts on federal policy. As a consequence of that report, long-term care is no longer synonymous with just nursing homes. And our understanding of residents' needs, preferences, and values has improved, along with our assessment of nursing home quality. It is our hope that this National Academy study will be as monumental in changing the quality of long-term care in this country. Next slide, please. The current COVID-19 pandemic has highlighted and amplified problems in nursing homes, raising alarms and resulting in calls to re-examine the quality of care in nursing homes. It is not news to this committee that more than a quarter of all COVID-19 related deaths in this country have occurred in nursing homes. Several factors have contributed to large outbreaks of COVID-19, including fragmented financing for nursing home care, low staff wages, clinicians not often on site, lack of transparency and quality, cracks in the regulatory framework, not enough emphasis on infection control, and lack of owner accountability. It is our hope that this study will help to resolve these ongoing issues. Next slide, please. The Commonwealth Fund has three primary aspirations for this study, in addition to addressing the other issues that I've highlighted. We would like the variable quality and drivers of poor quality nursing home care to be well documented by the expert committee. Secondly, we would like to ensure that the study examines issues for older people in nursing homes, as well as younger people with serious disabilities. And third, it's important to us that the committee propose actionable ways for clinicians and policymakers to improve the quality of nursing home care. It is our hope that the study can have at least as large of an impact on our long-term care system as the last study on nursing home quality, resulting in improved accountability, better clinical management of care, and improved quality of life for nursing home residents. So thank you very much.
Thank you, Gretchen. We will continue to hold your words as a charge for us, and we are already, I think, all committed to the day that we can deliver to you and to all of our funders a report that really meets these great expectations. We really appreciate your words. Next, I'll call on Joshua Hoffman, the Executive Director of the Sephardic Foundation on Aging.
Good afternoon, everyone, and thank you for inviting me to the launch of this extremely important and timely study. 2020 has certainly been a wild ride for all of us, something that we have not seen in our lifetimes. And 2020 is also the first year for our organization as a private foundation. The Sephardic Foundation on Aging was a nonprofit nursing home in Brooklyn, New York for over 60 years, providing high quality care for older adults. Known as the Sephardic Home for the Aged, our organization spent decades caring about the issues that will be discussed and approved upon by the members of this committee. That's why our board unanimously voted to support your work and efforts to improve the quality of care in nursing homes. COVID-19 has brought the issue of quality of care in nursing homes to the forefront of our media coverage and, probably more importantly, our dinner table conversations. Families are starting to have end-of-life care conversations and are realizing the importance of quality care in nursing homes. No one wants to be admitted to a nursing home, and many people do not plan for that either, but for many it becomes a necessary part of end-of-life care. And how we as a society provide that care needs to be deeply looked at, analyzed, and improved upon. And on behalf of the Foundation's Board of Directors, I thank all of you for accepting this responsibility and for generously giving of your time, experience, expertise, and knowledge so that nursing home care can be made better for those that need it. We hope to see a report with actionable steps that can be taken to revamp the structure and quality of nursing homes. Specifically, we're eager to see proposed changes to the current oversight and regulatory structures on care quality and strategies to improve the skilled workforce at nursing homes. Before I conclude, I would like to acknowledge the John A. Hartford Foundation for leading the charge on this issue and for their continued leadership in the field of aging, and acknowledge the Commonwealth Fund, the Jewish Healthcare Foundation, and the Fan Fox and Leslie R. Samuels Foundation for their support and leadership of this most important endeavor. Thank you again, and I look forward to seeing what we can accomplish together.
Thank you so much, Joshua. We really appreciate your support. We now will hear from Karen Wolk-Feinstein, the President and Chief Executive Officer, and Nancy Zions, the Chief Operating Officer and Program Officer of the Jewish Healthcare Foundation.
Thank you, Betty. So this is a monumental day. I'm the CEO of what has become what is commonly referred to as a conversion foundation. No, we didn't convert religiously, but we came from the sale of the assets of the Jewish hospital in Pittsburgh. So the hospital sold because it was in effect forced out of business. The Jewish community in no way could support a teaching hospital as other competitors in the neighborhood started to make a play to take over, which they have, and create quite a large system of care. So the irony is we took this endowment, and one of the first acts that I and the board made was to put $35 million into a comprehensive regional network of long-term care services, meant to be high quality, state-of-the-art, home delivered meals, hospice, daycare, assisted living, low and moderate income senior living, and skilled nursing. Today, we announce we're closing the skilled nursing facility. I think everybody here knows why. We were just hemorrhaging money, and it certainly didn't help that COVID, even with CARES Act money, put additional strain. So today we met with our union. It's a very sad day. There are many tears here in Pittsburgh. But we're not the only one. As Terry mentioned, mergers, closings, acquisitions are going on now as people try to get out of this industry. So I don't think this committee could possibly be more timely. So we have to know also that over the last 25 years, long-term care in the United States has changed. Consumers really prefer staying in their home or, as with my family members, in assisted living with supportive nursing care long after they should have gone to skilled nursing. That is, if they can afford this expensive option. Seniors want, and they want to access more community-based care, but that isn't the right solution for everybody. So we need a variety of models. We have so few options in this country, and I hate to put the pressure on all of you, but we're depending on you. We're proud that at the foundation, I spent 6 years trying to get approved the Community Health Choices program in Pennsylvania so people could stay in their homes. And we're absolutely delighted that it passed, and we launched the first pilot in the Pittsburgh area and Southwest PA, but we still have people who need more intensive care. So skilled nursing is not going to go away. We also had the problem that others have, that the hospitals were keeping their Medicare rehab patients, and the Medicare rate would sustain a nursing home like ours, but we weren't getting the Medicare patients. We were only getting more and more Medicaid patients and losing $100 a day. So recently we commissioned a study from Leading Age Center at UMass Boston to build a case for increasing Medicaid reimbursement for long-term care. But I am very squeamish about the likelihood that this is going to solve the problem of skilled nursing. Medicaid is going to be under assault post-COVID. And I think we have to recognize that we're going to be there competing with a lot of others for the Medicaid dollar. I think this committee has to look at other options. We've got to get more creative in how we can finance worthy skilled nursing options. We're about to launch a documentary film we put together, what COVID-19 exposed in long-term care. Terry, you covered that so well. I'm not going to go over. I think everyone on this Zoom meeting knows what flaws were revealed by COVID. And our film wants to highlight how the pandemic's killing fields in nursing homes were predictable and preventable, and really a reflection of deep-seated problems. We know how tempting it is to find someone to blame, and maybe the easiest thing, let's see if we can't blame the nursing home owners and managers and frontline staff. There may be some that didn't manage an outbreak as well as they could, but these are also victims of underfunded, overlooked, and thinly staffed systems of care for our frailest citizens. It's almost impossible to deliver high quality care once a nursing home depends on a large proportion of Medicaid funding. So some of our best independent, faith-based, hospital-owned facilities are up for sale or merger. I think since March, our staff have been doing really worthy things that I call finger in the dike, finger in the dam, activities that aren't going to make up for the shortfall in funding that would allow adequate resources of every kind, human and not human capital, and so many things that are required to get through a virus like COVID, but also ordinary clinical care and clinical problems in a facility. So our staff, Nancy will probably tell you, have provided statewide education and training to 1,800 long-term care facilities under the CARES Act, and we're really proud of that work. We also are very proud that we do other fingers in the dam. We do a lot to keep seniors who are in skilled nursing homes from getting hospitalized. But I'm back to that same issue. The financing doesn't allow adequate multidisciplinary care. That is our challenge. So we're looking to all of you to be creative. We need better options, exciting options. We have no choice. The box we want to escape is neither satisfying nor safe nor viable long-term. So think about senior villages, CCRCs, greenhouses, Detroit river towns, I like Vince Moore's what I call pace on lock residential option. But they have to be affordable and they have to offer good clinical care. I mean, we have to keep that at the top of our wish list. Not to mention the wide range of clinical disciplines that are needed. So we also can repurpose things like co-housing, our NORCs, our smart houses, Beacon Hill communities, intergenerational communities. Maybe there are ways that seniors who are well can be part of this neighborhood, helping seniors who are fragile stay in their homes. I think we just have to be creative and think of every option, mostly right now because we don't have a choice. So finally, I think for all of us, we know this, COVID may not be the last virus that plagues the long-term care sector. We don't have a central agency capable of addressing the serious logistical problems that have led to so many unnecessary deaths in our senior residential facilities. So I apologize to Liz and Terry who heard me say this, but if nothing, I persevere. It's time for a National Patient and Provider Safety Authority, similar to the National Transportation Safety Board, that provides a centralized resource. And in the case of a pandemic, it could allow the rapid and equitable distribution of critical resources, and just make sure that the protective equipment that we needed, the testing and staffing, get to the settings where they're most needed. It's really been something of a disgrace, I have to say, sorry, Pennsylvanians, but we had plenty of supplies near our nursing homes, and the nursing homes were begging. We were looking abroad to find shipments from Israel or anywhere, even though you knew in your neighborhood there were adequate supplies that weren't being used. We have so much to learn from Singapore, Japan, and South Korea and other countries. I just hope we're humble and we ask the right questions and we go on an open mind learning expedition. So it's time to acknowledge that we didn't really manage this pandemic well in skilled nursing, but we can learn from it. We can't bring back the dead, but we can honor their memory with decisive reform. So I hate to put the burden on all of you, but you're our hope. Thank you.
Thanks. And I'll just take a minute to say that the Jewish Healthcare Foundation has just completed 8 years as a lead education partner for a CMS Raven initiative to reduce avoidable hospitalizations. And as Karen mentioned, we've spent the last 7 or 8 months working with our state on the Regional Response Healthcare Collaborative Program funded through the CARES Act. And here's what we learned in reaching out to those 1,800 facilities. While the frontline workforce in long-term care is on the whole a very committed and caring one, they often lack accesses to necessary resources that would help them on a usual day, let alone in a pandemic. But when they were paired up with other community partners, they stood a much better chance. So here is my personal hope for your work, is that you will be able to find a way to make some of those short-term interventions available and sustainable in the long term, revamping the role of a clinical lead person in skilled nursing, be that a physician or a nurse practitioner, that specialty services for palliative care and end of life, behavioral health, dementia, infection control, pharmacy are all accessible and made part of usual care, and that we bridge communications, supplies, and technology gaps between acute and post-acute care services, and that we absolutely find a way to invest in our workforce, both by improving their skill and providing them with some career paths and livable wages to those who commit to the care of our frailest. Thank you.
Thank you so much to both of you. I think, our statement of task goes beyond response to COVID, but we've all recognized that it really has been the COVID pandemic that's created the alarm that we really can no longer ignore this enormous human concern. And I really appreciate your comment about those who have died. We can't change that, but what we can do is to make sure that our work really honors those whose lives have been lost in nursing homes. And so to keep that image with the committee, I think is so valuable. And I thank both of you for your passion. And now our last funder, Julio Urbina, if will be representing the Van Fox and Leslie Samuels Foundation.
Hey, good afternoon, everybody. Well, it's not fun being the last one in such a smart group of folks because pretty much every checkbox has been checked with all the things that you guys have said. But I did want to introduce you to the Van Fox and Leslie R. Samuels. We are a local funder. We fund in the 5 boroughs of New York, and even though local sounds small, we are talking about 1.2 million older adults. And our mission is to improve the quality of life of those older New Yorkers. And I know it's a very broad mission, but we purposely left that mission broad so that we can consider a number of variables that have an impact on people's quality of life. So we like to say that we go beyond public health policy and really look for healthy public policy. Wanted to thank Terry and the Hartford Foundation for inviting us to participate in this endeavor. We've have a great relationship with the Hartford Foundation. We've taken advantage of the very various models that they've developed over the years, like Niche and ACE and Impact. And it really allows us to kind of make retail changes to long-term care. But we really are looking forward to making a wholesale contribution to the way long-term care is delivered to our older adults in New York, as well as in the rest of the country. We do fund direct services, but for us, this is an opportunity to help change the environment, that our grantees are currently operating in. And in addition to all of the things that have already been mentioned, I want to, I'm hopeful that this committee will look at telehealth. And not as a replacement of care, but as a complement to the care that is already being provided in long-term care. We feel that, COVID has brought a number of things to light, but has also brought along some opportunities, including, I guess, the reinforcement or the validation that telehealth and subsequently the reimbursement for telehealth operates well outside of a rural environment, and again, can be a complement to quality of care. I do ask that the committee think about what barriers currently exist that prevent organizations or care providers to apply the innovation that has been seen over the last 32 years since 1986, and what can be done to change that environment to allow these folks to do that work. For example, I think there's been more than one mention of the greenhouse model that we tried to bring in New York City, but at the time, New York State regulations required a certain square footage in patient's room, and that one, policy, prevented folks from implementing that model in New York City. So again, I want to thank the Academy for including the Samuels Foundation. We're proud to be a sponsor, of this study. Remember who we're focusing on, and those are those older adults that are in long-term care facilities. Please remember to go beyond public health and think about all of the healthy public policy that can be considered to improve quality of life. And the one thing I do want to say, and may not be too appropriate, but I started out my healthcare career as a paramedic in New York City. And when we used to get called to render care at a long-term care facility, the joke was always that we would play rock, paper, scissors at the beginning of the call to figure out who was going to intubate the patient and who was going to yell at the staff. We've seen a lot of significant change and improvement in the long-term care setting since then. But I remember having this conversation after Katrina. And hopefully, some of the lessons learned from COVID are going to stick. And we do ask you to please focus, on those older adults, as has already been said, who have passed away, and to use their memories to, develop a plan to improve long-term care going forward. Thank you.
Thank you very much. It's really a gift to the committee to have this first day start with the 5 foundations, because we know that each of these foundations brings a wealth of knowledge. You are individually professionals who have spent many years committed to this field of better care for older adults. Your foundations have tested models, you have rigorous evaluation, you have a broad view, and so we know that we have you at this virtual table today with a lot to share. So we have about 30 minutes, and what we would like to do is to ask our committee members to use the hand raising function in Zoom, and then one of the staff members will call on you to try to keep this as organized as possible to ask questions. You could address a question to any one of the individual foundation leaders with us today, or you could ask an open question, and then again, we would ask the foundations to raise their hand in the function to offer to respond. So looking forward to this 30 minutes that we can have some interaction with the committee and our foundations.
Betty, it looks like the first hand raise is Dr. Konecka.
Hi, this question is, first of all, thank you for those presentations and for sponsoring this work. My first question, I guess, starts with Terry Fulmer, although anybody could chime in on this. Terry, you started out talking about the need for, bold, fundamentally different new ideas. But then you and others have also talked about the need for actionable recommendations. And to me, that presents a broad spectrum of possible recommendations that could come out of this committee. And somewhere in between there lies the challenge of political feasibility. And, you can imagine what's on both ends of those, the sort of really bold, fundamentally changing the whole way we finance long-term care to sort of very incremental quality improvement steps or, different ways of, accessing care, et cetera. So to what extent would you like to see us explicitly consider or explicitly ignore the political feasibility of what we're recommending?
Thanks, Tamara, and congratulations on your recent paper that's gotten so much press related to the spread of this COVID virus and for all your research. So my answer to you is we have to do both. There will be incremental steps, there will be bold visionary steps. Here is what gives me optimism. Before over 87, if you were a nurse in a nursing home, you used a great deal of physical restraint and chemical restraint. Look what happened. That was bold and actionable, and it transformed the way in which people resided in those facilities. So I think that I've had the privilege to serve on some of the National Academy's studies, and the process works. You will come together and you will have, as a committee, the members you will continue to titrate, if you will, your recommendations, and you will have both. And one does not know the political climate at the time that the report is released, but to do anything less than to be visionary, and say, we think we need to change the structure of payment for long-term care. And you could make the recommendation the way that you want, and I will not get into details of what I would think, because that's not my job. But I have great faith in you all, and I know that you'll do it, and you're going to be balancing one another as committee members.
The next person with their hand raised is Dr. Sloan.
Thank you. I actually had a couple questions. The first one was very similar to Dr. Konecka's question, so I won't really say anything other than if anybody has any more ideas on how we should reconcile a focus on immediate fixes with long-term vision, any other tips would be great. But the other questions, the next infection challenge in nursing homes will not be COVID, but something different. And so how can we avoid being too influenced by what we've observed in COVID-19? That's one question. The other one is, and this is more general, I'm kind of tired of regulatory sticks being applied to what is basically a structural problem, and by no means a behavioral, that's not really bad people, it's a structural problem. How can we avoid falling into that trap?
So I'll start and others please join. If I'm not mistaken, let me think, I'm the only clinician who's a funder at this moment. My other colleagues are policy experts, thank goodness. So as a clinician, I would say that infectious disease is infectious disease and it'll always be present and worrisome. And this work will improve quality and safety in nursing homes. And I think that most recently, what the airlines have fundamentally changed everything about their model of cleaning and operating. And I have to believe in the United States of America that we can figure out how to get infection control in the right place. The second thing that you talked about was structural problems, I think. But would you, or restate it for me, your second part?
I basically said that regulatory sticks being applied to a structural problem
Yeah.
doesn't necessarily solve the problem.
Right, right. You know, we need incentives, and we know what incentives can be, and professionalizing the workforce in long-term care. How many of us know a nurse who is ashamed to say she works in a nursing home? That's a problem. So I think that we need to take a cold, hard look at the things that encourage people to participate, the quality of a living wage. We just can't keep saying, oh, we can't afford it. Then why? I don't want to get into it, but to say that, let's buy 10 more MRIs while we're at it, okay? So you guys, we're looking forward to your good ideas. Julio, did you want to jump in on that?
I believe Chair Feinstein also would like to
Oh, good.
respond,
Thank
and
you.
Nancy.
Well, and we can keep going on this. I actually wanted to respond to the question about political feasibility. So if Nancy wants to go first, that's fine.
Thanks. I just wanted to, I don't think the infection was the thing with COVID. I think that the systems were so close to the edge that any disaster of any kind was going to put them over the top. And I look at the issue of staffing, and I think to myself, the staffing was horrific before, the turnover was awful. If a major factory or a major company moved into our city, we ran the risk of people leaving long-term care to go take those jobs. It didn't have to be something that itself was the reason why people immediately died. But the lack of attention to the workforce is an issue that this underscored for us. It could be cybersecurity issues coming up. It could be a weather-related emergencies. We just found out that we didn't have skilled nursing facilities able to withstand any kind of additional stressor. In this case, everybody felt it all at once, as Terry mentioned earlier, but it could have been something smaller and more localized, and they still would have been unable to deal with it.
Right.
So my comment was more about political feasibility. And, one aspect is, of course, what are we going to do when we have spent all this money on COVID? And how could you ever ask for more money for anything when everyone's going to be looking at deficits and whatever? But there's another issue other than the political issue. And I really think that's the perceptual issue of being a senior and being a frail senior. And I guess I'm not alone. I sort of had it with ageism and the negatives about being older. So even though I love Saturday Night Live, I've about had it with Colin Jost. Every week there's some nasty comment about the old people who are kind of ruining the country. But it goes much deeper. I mean, the whole expression, okay, boomers, it's very insulting. And I also, you notice my name is Karen. Once we can't use all the other nasty terms we often use for people of different ethnicities and races, we've now found other ways of being negative. But we just lost about a week ago. We had the funeral for a 100-year centenarian on our board. Never missed a meeting, did finance and audit, did distribution. He was a very valuable member of our board. We all absolutely adored him. Full of life and energy, but also very sharp. I think the one thing you have to do, I've done fundraising, as many of you have, you got to soften the market. There's political feasibility, but I also think there's a perceptual cultural attitude toward aging. We went to Spain and Japan recently, and we looked at their aging systems. They really do have a very different attitude toward their seniors. And I think we're ready for a correction here.
I think the next hand raise is Dr. Grabowski.
Great, thank you. And thanks to all the funders for your support of this work. Dr. Konecka kind of raised one tension here of being bold versus political feasibility. I wanted to raise another one, and I think a couple of you, Terry and Karen in particular, touched on this in your remarks. This tension between the issues in nursing homes, which we all know need to be addressed, versus kind of nursing homes living in this broader long-term care system and even healthcare ecosystem. How do we think about reforms to nursing homes? Some of them may be blurring into long-term care reforms, and we know work needs to be done in both of those areas, but help us think about your vision in terms of addressing the problem with nursing homes, which we know is front and center here, versus kind of broader, the need to grow home and community-based services, for example, and Karen spoke about kind of different PACE models and so forth. How do we think about those alongside one another? Thanks.
Thanks, David. Karen, do you want to start?
Well, we wrestle with this. It's been an issue. It is, it's a scale, right, of need and disability and services that are appropriate. And often one thing interesting about the scale is that partners can be in different places. So two people living together, could be at very different levels of frailty. So things are getting more complicated, right? So we do need to deliver services in the home. And as many of you know, if you can afford it, for many of us, we did keep our relatives in the home or assisted living, but it's really expensive long after they needed skilled care. There's no simple answer. I mean, we've got to build everything on that continuum, but there is going to always be a need, and people want to think, and maybe I was as guilty as anyone when we were advocating in front of the legislature in our state, saying that if you put more money into community-based care, maybe, you would, we use that argument, to be honest, you'd put more money into skilled nursing. But now I feel very guilty about it because it was kind of a way out. And I know this is hard. You've got to play all the notes on the xylophone. And also when you think of two people living together who are both seniors, you can have very different notes that you're hitting. And so that kind of flexibility, that continuum, that xylophone, I think we have to play every note.
The next hand raise is Dr. Tucker Seeley.
Hi, so while I heard vulnerable being referenced to older adults, I heard very little about the additional demographic characteristics that could make someone more vulnerable, such as race, ethnicity, which we saw structural racism being highlighted a lot over the summer, and also socioeconomic status, which definitely impacts the amount of financial resources that households have available to them as they navigate long-term services and support. So if you could help me to understand what your vision is around these other or additional intersections and the things that we should focus on here.
I'm happy to begin and say, Dr. Tucker Seeley, it's nice to see you. I did say that, and I did have it in my slides, and it is front and center in the work that we do. We had disproportionate harm for older adults who are poor and who are of color. And I believe I said it more than a couple times, but you know what? You can never say it enough. Why did they disproportionately suffer? It's the same thing as older people. It's valuing, it's racism, it's a lack of commitment to equity. And so I expect your good mind to be on that issue throughout this study.
Assistant Secretary Greenlee, I noticed your hand was raised earlier. Would you still like to make a comment, question?
Oh, thank you. Terry, I have a question for you. You mentioned the work that you're doing with frameworks. So I want to come back to that. Here's my question. The politics piece always catches my ear. And I'm fairly convinced that no legislator really understands who we're serving in nursing homes with regard to Medicaid. That all of the stigma about Medicaid is both inappropriate, but it's also sometimes just wrong. That old age impoverishes people, and you do have people who've been lower income or poor who grow old, but the very cost of spend down a nursing home means that often we're serving the middle class who are now cash poor but have monthly income, and that people don't know we're serving our grandparents and our parents. And so because of the Medicaid stigma, it's always another population that we don't know. And how will your frameworks work kind of get at this issue of who we're actually serving in this particular setting?
Thank you, Kathy. And I will make a point to chat, I'm not going to chat it in because it won't be the most effective way, but I'll send Tracy Lustig the proposal that Frameworks is working on for the benefit of the committee, so that you can be part and parcel of the way that they're moving that ahead. We called Nat in March and said, can you stop what you're doing and help us? And to his credit, he did. So we'll get that material to the committee so that it can be a part of the information you take a look at. I was hoping Gretchen from Commonwealth would also just make a statement about any ideas you have related to this notion of Medicaid impoverishment and what bundled payments might hold for that. I don't know if you can comment on that at all, Gretchen.
Well, yes, but I also wanted to comment on the previous comment about the vulnerable populations and what makes them vulnerable. The framework that I always use is it's people who don't have the resources to really advocate for themselves. And I think that's a helpful framework for thinking about who really needs the most help. In terms of bundled payments for Medicare and Medicaid, and in terms of how that might fit in here, I think that's a really great question for this committee, and in terms of whether or not payment reforms like that would really address the problems that we're seeing, or if you really need something larger than that.
That's helpful.
Thank you. We have about 13 minutes left and 5 other committee members that would like to make questions. So please, we want to try to get to everybody, so please try to keep your comments and responses as brief as possible. Next is Dr. Ersic.
Thank you, and thank you to our funders. I wanted to ask a broader question, and Karen, I think you raised this a bit in your remarks about public perceptions around aging. Terry, I certainly resonate with your comments. You know, if you are a talented nurse, if you're a smart nurse, you're going to rush yourself to an ICU and not to a nursing home. I think as educators, we play into that, but I also wonder what our funders think about this broader notion of public perceptions as shaped by the media. The narrative around nursing homes is almost always uniformly negative. And how would you say our work should address that?
I'll just say a little bit, Marian, nice to see you, and then turn it over to other funders. That is why our foundation turned to frameworks right away, because it's fundamentally not true and not fair that every nursing home is a death trap, and you know, people have just used the most horrific euphemisms. But we do know that we saw some very egregious behavior for some, but we need a denominator. This is the National Academy of Science, Engineering, and Medicine. And so all of you will make recommendations about how we will get ahead of the denominator next time. Nursing homes did not have to report cases. They didn't have to test. They were not given PPE. We have no idea of what the denominator was in the early months of this. So as we catch up, what would this committee say we must do in order to get truth into a paper. You can't do anything about the New York Post. It's going to do what it does. But we do need good, solid data to refute or understand what's being said.
So we're doing a documentary, as I mentioned, because I am so concerned that we're painting all skilled nursing facilities with a bad brush. So one thing in our state, our Attorney General, very bright, interesting young person who may be our next governor, we don't know, but he went after the nursing homes. I mean, that was his first instinct. Let's have more regulations. And literally, the state regulators were showing up at homes as they were struggling with COVID. I mean, they were frantic, trying to control the infection. And then suddenly they had an inspection. So we talked directly. It was really good, had a really nice conversation, and with our senators, who are both champions of seniors. It's a really big issue. And one way of being productive about it, I think, is to look at the right regulations, but also, and one thing the committee could look at, what do we do with them? So everyone's probably heard about Brighton, which is unfortunately our local black eye, an absolute disaster, death trap. It had so many deficiencies. Our state does a good job of inspecting. They do a lot of inspecting. And Brighton had, after it was taken over by a for-profit, a long chain of deficiencies. But so what? You know, it kept operating and then disaster hit. So we need the right regulations, but then we need to do something. And what bothers me is once they put the STAR system up, it doesn't matter. Families do what's convenient. Any of you who've cared for seniors, you know that. If I have to stop on my way home every day, I am putting mom or dad where I can stop. Even if the 5-star place is in Cleveland, I'm not putting them in Cleveland because it's not on my way home. So I do think having the right regulations and bringing up the ones that are at the bottom is a critical task.
The next hand raised is Dr. Travers.
Thank you. Dr. Sloan brought up structural issues, and I wanted to interrogate that a little bit more, particularly where we are seeing disparities during this pandemic, not only based on the characteristics of the nursing home and on the community spread of COVID, but based on the communities where the nursing homes are located. So thinking about the resources that are in the community that may impact the services, supports, and personnel that the nursing home has access to. What extent do you feel that this charge extends to the issues that are salient in the communities in which these nursing homes are located?
Julio, do you want to lead?
Okay, there, I'm unmuted. Yeah, I mean, there's a number of things I'd love to say. I mean, one, let me just go back to the whole public perception piece. You know, Live On is an organization that's in New York City that represents senior serving organizations, and they've been very successful in implementing some of the framework tools, and they credit you know, kind of that change in people's perception on what an older adult is or who an older adult is, and the subsequent increase in some of the funding that's gone in, you know, to services for older adults through the city council. So, you know, there's great work that's being done in changing people's perceptions. But as far as the resources that are located in these communities where some of these long-term care facilities are, you know, COVID didn't cause this, it just brought it to light. And, you know, just again, kind of sticking to that public perception piece, you know, we have an issue with how these care providers are being seen or being perceived even within, you know, the nursing home environment and even within, you know, the healthcare environment. I mean, we funded a project a number of years ago that taught nurses' aides how to identify and how to communicate palliative care needs to nurses and physicians in a long-term care facility. But it never really worked because the nurses' aides, the information that nurses' aides were providing to this higher level of care or professional wasn't seen as valid because it was coming from a nursing assistant. So I think that there are a number of structural issues even within the long-term care environment that we have to change. I know that doesn't answer the specific question, but I think that there are a number of structural issues that were brought to light because of COVID and not, you know, caused by COVID.
Dr. Alexander.
Hi, thank you. So I have a question just in regards to the talk about nursing home edges. So most of my career has been on technology innovations and their impact on quality in nursing homes. That's where I've been mostly focused on my career. I think Mr. Urbina is the only funder that really mentioned anything related to technology with telehealth. As I think about this problem, our focus is on nursing homes in this panel. Yet when you consider innovation and you consider anything related to technology, it always brings in other contexts with the edges of the nursing home, acute care providers, patients, families, through portals that may not even be managed by the nursing home. So how do we, as a panel, consider all of these sort of things that match up with our edges in our thinking? Is that where are our limits in the sense of our boundaries as we set our goals and our directions?
So this is Betty. Let me just interrupt for just a moment. Obviously we have such good questions and such interest, and yet I know some of our funders have a hard stop that they need to get on to other meetings. So if we could, I see Terry's on the screen. If we could just have Terry's comment, and then we'll need to wrap up.
Okay, and Betty, if it's okay, I'm just going to ask Joshua if he wanted to jump in because he's one of the funders who hasn't yet been able to do that. And maybe he's comfortable, yes or no. Okay, I don't see him coming off mute, so I'll say the following. I care deeply about the edges that are around us, and I think that your task would be impossible to stay agnostic on it, but focus on nursing homes. There could be more studies other times, and think about what your recommendations would be to inform that work as well. And I'm all for technology, by the way.
Great. Thank you so much. I really just want to take this moment to thank each of our funders. I think all of us would agree that what we have heard today is not just, a message of the current thinking of the funders, but really lifelong commitment by each of you as individuals. You've brought your own passions and hearts to this discussion, and we so greatly appreciate, because of you, we will be able to do this work, and I can assure you that all of your words will stay with us through the many months ahead. So I will ask our funders if they would like to exit now. Again, thank you so much for spending this time with us. And then for the committee members, we now have a 15-minute break. So we're right at the hour of 3 o'clock. If you remember, we'll need to sign out of Zoom, sign back in using the last link that you have. And then as soon as we rejoin, we will be taking a little time for debriefing and hearing from each of you as committee members about your thoughts and reflections of the day. And a special thanks to all of you who asked such great questions. Really appreciate that. So back in 15 minutes.